This is a rare case of STEMI secondary to spontaneous coronary artery dissection in a woman with fibromuscular dysplasia and coronary atherosclerosis. Spontaneous coronary artery dissections have been associated with fibromuscular dysplasia, especially in younger women. Individuals with spontaneous coronary artery dissections predominantly have a lower prevalence of traditional cardiovascular risk factors compared to those with atherosclerotic myocardial infarction. We present a case of a woman with both fibromuscular dysplasia and coronary atherosclerosis who presented with ST elevation MI secondary to SCAD. A 60-year-old woman with a past medical history of hypertension, hyperlipidemia, and long-standing tobacco use presented with acute non-exertional substernal chest pain that radiated to the left side of her face and arm, which improved with nitroglycerin. The initial EKG demonstrated a slight ST elevation in lead V4 with a J point that progressed to 1 millimeter after serial EKGs. Troponins rose from 8 to 576, then 650 nanograms per liter. A left heart cath demonstrated a SCAD extending from the mid to distal LAD with a TIMI flow of 2, 70% stenosis of the mid LAD, 40% stenosis of the left circumflex artery, and 85% stenosis of the RCA, in addition to apical hypokinesis and a left ventricular ejection fraction of 60%. As you can see in the figures panel, the top image demonstrates a left anterior oblique cranial view demonstrating a coronary artery dissection in the left anterior descending artery indicated by the white arrow. And in the bottom panel, you can see a digital enhancement of this photo demonstrating a false lumen indicated by the white arrow. In terms of management, she was managed with high-dose aspirin, 325 milligrams, high-intensity statin, and anticoagulation. The spontaneous coronary artery dissection was managed conservatively with beta blocker therapy. She later underwent PCI with placement of a drug-eluting stent in the RCA. She was discharged on DAPT for 12 months. She was later switched over to indefinite aspirin and maintained on beta blocker therapy to reduce the risk of SCAD recurrence. This case highlights spontaneous coronary artery dissections occurring in the context of underlying atherosclerosis. Medial atrophy and scarring have been hypothesized to limit the propagation of these dissections within coronary arteries. Medical management remains the mainstay of treatment, as PCI has been associated with major adverse cardiovascular events. Beta blockers in these instances may reduce arterial shear stress by lowering the heart rate and blood pressure. Observational data has suggested they decrease the recurrence of dissections.